All right, good evening, everyone. Dr. Twyman. For those that are new, welcome. I got a lot of new followers after doing the interview with Dr. Lyon yesterday. That episode should drop, I think, in a couple weeks. I'll let you guys know when that one's going to. Dr. Lyon's been a good friend since 2019, right before I launched Apollo Cardiology, and my practice is located in St. Louis, Missouri. And we focus on the early detection of vascular disease and really try to help people reduce the risk of heart attack and strokes. So been doing that for the past 6 years or so in practice by myself. Prior to that, I've been a cardiologist since 2012 and been a physician since my graduation of medical school in 2002. So I've been doing this a minute. So seen a lot of things. I've seen a lot of people, unfortunately, succumb to their vascular disease. As I talked about in the podcast yesterday, every 40 seconds, somebody has a heart attack. And my goal is to try to really help make sure it's not the person who I'm working with. So there's a lot of things that drive vascular disease: endothelial dysfunction, disruption of the glycocalyx, oxidative stress, inflammation, dyslipidemia. I talk about a lot of those things in many of my prior podcasts, as well as the one I did yesterday with Dr. Lyon, but also talked about testosterone replacement therapy in men, the safety from a cardiovascular standpoint. Talked about GLP-1s, particularly the SELECT trial, which showed decreased major adverse cardiovascular events in patients who had known coronary disease and obesity. They had 20% less heart attacks, strokes, and deaths when they took the medication semaglutide, Ozempic. We also talked about red light therapy, photomodulation, one of the topics I kind of picked up back in 2017, 2018 when I started learning much more about quantum biology. Thus, the reason for the blue blocking glasses is something that I figured out around that time, was that if you control your light environments, you really help optimize your sleep. So been using a sleep tracker for 9 years. Sleep is optimal, probably top 5% for people of my age. Not as a brag, but I highly prioritize my sleep because that's when the mitochondria are doing the repair. So for those that are new, again, welcome. Every Monday night, 6 p.m. Central Time, we do these Ask Me Anythings. So I put the story up earlier in the day, usually Monday mornings, and people submit their questions in the chat box. Also, if there's other questions as we're going along today, you can drop them in the comments and I'll answer them after the pre-submitted questions are done. A couple more housekeeping things before we jump into the pre-submitted questions, which many of them were great and a lot of value to be had for the people who asked them. The one kind of housekeeping thing is I've been talking about a kind of a low-key retreat at the Canyon Ranch in October. The dates are going to be October 31st to November 2nd. I will get a little bit more details on a kind of a sign-up type of website on my page soon, and I'll put a link also in my stories. It's going to be a very, kind of relaxing event. I've been to Canyon Ranch a couple times before. One of my favorite places in the world, particularly from a kind of wellness recharge standpoint. So if you need a little bit more help on optimizing your exercise, they got all the exercise, nutrition type of things you can do there. Stress management, there's a few biohacking toys they got there now. They got a bunch of red light therapies and different devices that can optimize mitochondrial function. And then I just really enjoy the hikes in the mountains early in the morning before it gets to be like 110 degrees at some days. So if you're potentially interested in that, you can drop a comment. You can send me a DM or just be looking at my stories. I'll send some information there. And then the second question, I know if I start getting when the podcast with Dr. Lyon drops, is how people can work with me if they're interested in that. If you go to my website, drtwyman.com, there's a link that is a kind of a short form application. Why do you want to work with us? Where do you live? And then one of my team will reach out to you, set up an onboarding call, make sure that the logistics are explained to you, how it's best to work with us, and we can see if we're a good match. And then lastly, my practice is still open to new patients. It's just myself and two team members who are outstanding, Cassidy and Dow. For those that know them, they're really the heart and soul of the practice. I'm the person who kind of just puts the plan together, and they're helping run it for me. So we're a small team, but we're a very well-oiled machine for those that have seen us previously. But the plan probably is in 2026 that I will not be open to new patients and will likely be transitioning to a membership model, not a mandatory one, but an option for patients that want to continue to kind of lock in with us for long term, because we're getting more and more people who want to work with us, so we got to be judicious with our time, and the people who want to be proactive with their health, we want to make sure we have time for them. So be on the lookout for more details about the membership option. That'll be really launching in 2026. So with housekeeping out of the way and greetings to the new people, we'll work on driving some of the risk factors down for cardiovascular disease. So somebody says their volume is low, so I have a professional microphone in front of me. My voice is maybe a little bit down from the podcast yesterday. It was over 2 hours long, and saw a full host of patients in the office today. So just double check your phone to make sure that it's not on your end, because I've had this issue in the past, but it hasn't been a problem with this microphone in quite a while. So, all right. So jumping into the first question. How serious is a PFO, pain foramen ovale? Everybody is born with one, but 20% or so of the population has one that remains. So it's a connection between the left atrium and the right atrium in the heart. It's the way that when you're in utero, the blood passes into the left side of your heart, and it already has oxygen put into the blood from your mom because your lungs aren't working when you're in utero. So when you come out of the womb, the flap of tissue closes and the blood generally does not transmit to that hole anymore. But in some people, again, up to 20% of the population, it may still stay open. Can increase the risk of stroke in some individuals. May be a risk factor for migraines in others. Many years ago, there's more push to close them percutaneously. Now it's more if a person has had a stroke and there's no other obvious causes, then they consider closing the holes. Oftentimes people are recommended to take aspirin, generally low dose, 81 milligrams, if they have one, if there's not a issue with peptic ulcer disease or bleeding diatheses. So very common, diagnosed by echocardiogram with a bubble study generally. So if you have one, not always the biggest deal, they're pretty common. Next question up tonight, what is the best exercise for heart health? There isn't one particular. Exercise is one of the best things for cardiovascular health because of blood flow going across the endothelial glycocalyx. It's stimulating underlying endothelium to release nitric oxide, and that's the key. Nitric oxide's the signaling molecule and hormone that helps dilate the arteries and basically prevents things from sticking to the arteries. So anything that increases the heart rate and flow across the arteries is going to increase the nitric oxide release. But it's somewhat of a trick question. No, you can't only do cardio, and no, you can't only do resistance training. It's generally best to do a combination of both. So seeing some familiar faces tonight. Welcome, everybody. All right. Next question up. Can a high-fat meal the evening prior to an AM lipid panel double the triglycerides over the normal baseline? I've not previously seen that. I guess it's possible. Would think that you potentially have an issue with lipoprotein lipase if that's the case. A GB Insight genetic panel could tell you if you have certain genes that affect your triglycerides when you eat a higher fat meal, but that would not be a common response. But in my practice, I generally like to see triglycerides less than 80. Next question. It's probably not something I can answer in 2 minutes, but I'll give you a good starting point. So, what are the causes and the solutions for high blood pressure? The short answer is it's likely genetic, polygenetic etiology. So, if you do a CardiaX panel from Vibrant America, which is probably the top hypertensive genetic panel out there at this time, you generally start realizing people who have high blood pressure have somewhere between 5 and 10 genes that tend to increase their blood pressure. And that panel can give you an idea of what nutrition strategies might work better for them, if they're on medications, which meds tend to work better, and how sensitive the person is to caffeine. So many causes in general, you want to look at reversible causes. So, does the person, abuse stimulants, caffeine, nicotine? Do they drink too much alcohol? Do they have uncontrolled sleep apnea, significant oxidative stress or inflammation? Treat those if you can. But if not, you want to use whatever treatment you're comfortable with to get a goal of blood pressure less than 120/80, because the risk of stroke and heart attack starts increasing when it's over 115/75. As I mentioned a little bit earlier, exercise helps boost nitric oxide. Low nitric oxide is often seen in patients who have elevated blood pressure, and you can do multiple tests to figure out what's driving the low nitric oxide. And I talk about that in pretty detail with Dr. Lyon on the podcast that should be released in a couple weeks. Yeah, very pertinent question. How does excessive heat affect the heart and the arteries? Yeah, I'm in St. Louis. It's pretty toasty right now, very, very humid. When I was in the military, I took care of the Marine recruits at Paris Island, and it would be well over 100 degrees in July, and we'd have recruits passing out left and right, and they'd have rhabdomyolysis from the heat shock. So heat stroke is the major concern, with not being able to regulate your body temperature. But pre-syncope, you can actually nearly pass out or pass out. You could potentially have some electrolyte imbalances, which can cause arrhythmias. So best to stay hydrated. 80 ounces or more water a day. But you often need electrolytes if you're having significant sweating. So personally, I like LMNT. I just like the flavor of them. No affiliation with them. I buy it with my own money, but I like things that don't have sugar in them when I'm adding them to water. So. Question about LPA. So any studies or data that, this isn't the LPA one, so different question. So any studies or data that energy drinks have negative health effects or the heart in otherwise healthy individuals. Don't know of any randomized controlled trials on it, but in my experience, some people are much more sensitive to caffeine than others, and there are some energy drinks that have very high levels of caffeine. So most people, can tolerate maybe up to 400 milligrams of caffeine a day. If you're a faster metabolizer, maybe a little bit more. But if you're doing energy drinks and you're getting palpitations, your blood pressure is going up, you're having trouble with sleep, you really should be cutting back on that in that case. But definitely I've seen people have significant kind of palpitations. I've seen some people potentially have supraventricular tachycardia. I've not seen anybody flip into AFib with energy drinks, but you got to know what else is in the stuff other than just caffeine, because some of them have some things that the B vitamins, not a problem, but if you're taking other B vitamins, sometimes you can kind of overdose yourself if you're drinking multiple energy drinks a day. All right. Here's the LPA question. So, is there any research showing that lowering LPA via PCSK9s reduce mortality or events? So, for those that don't know what that means in English, lipoprotein A, it's a genetically determined particle, lipoprotein. Everybody has LPA, but again, about 1 in 4, 1 in 5 people, so maybe up to 20% of the population, has elevated levels of these lipoproteins, which generally may increase the risk of stroke or heart attack by twofold over somebody who does have normal levels. There are no drugs on the market today that significantly lower LPA. The only thing that significantly lowers it is blood apheresis. So I personally have never sent anybody for that. That's where they would take your blood out, spin it through a machine, give your blood back, and have removed the LPA particles. But that is only going to last, maybe up to 2 weeks, so you got to keep going back forever. So unless you're really into going to the hospital a lot, most people aren't signing themselves up to do that type of procedure. And it's not super common in the United States, a little bit more common in Germany. That being said, the PCSK9 inhibitors like Repatha and Twyman being the most common ones people have access to, they may lower lipoprotein A 20-30%, but have not seen data that that's really clinically significant. Most studies that are looking at the LPA lowering drugs are lowering LPA well over 85%, and in that case you're expected to see lower events. So those drugs, there's at least 5 different types of lipoprotein little a lowering drugs that are in development. None are on the immediate horizon to be released. The phase 3 trials from the FDA are still being completed. There's hope that some of the data will come out in Q3 or Q4 this year, with one of the drugs being released to the market potentially end of the year or early next year. But they're waiting to show that lowering LPA with drugs actually lowers events. That's what the FDA's hurdle is to get these drugs approved to the market. Question about calcium score test. So, do calcium score tests show where the plaque buildup is? Are they that specific? So, a CT coronary calcium score is a low-dose CT scan that looks for hard calcified plaques in the walls of the coronary arteries. Those are the arteries that provide the oxygen nutrients to the heart tissue. So, calcium is supposed to be in your bones and teeth, not supposed to be in your arteries. So, any calcium score above 0 is abnormal. So, higher scores, higher risk. So scores over 400 are high risk, scores over 1,000 are very high risk, and I have seen a score over 7,000. That's the world record I've seen so far. It will generally tell you which of the 3 coronary arteries the plaque is present. Is it in the left anterior descending artery, the circumflex, or the right coronary artery? But what it won't tell you is it will not tell you how much soft plaque is present, and it will not tell you how much stenosis or how much the lumen of the artery is being restricted by the plaque buildup. So how much of the artery is blocked essentially. So mostly you just go off the total score. Sometimes it's useful to know which arteries have more calcifications. If the person ultimately becomes symptomatic and you do a stress test, you often will figure out which artery is ischemic by the artery that tends to have the most calcium in it. But that's not always the case. Is soft plaque more dangerous than hard plaque? The short answer is generally yes. So why don't we do a little quick review? How does plaque actually form? So you have 60,000 miles of blood vessels. The arteries are lined with a layer called the glycocalyx. It's a protective gel coat made of carbohydrates and different glycosaminoglycans. Think of a fish coming out of water that's slimy. That's kind of what your arteries are coated with. If that coating gets damaged, the underlying endothelium, which is only 1 cell thick, will not have the ability to release sufficient levels of nitric oxide. And without nitric oxide, the arteries get stiff, the blood pressure tends to rise, and it's also like kind of having a force field down. More likely that the cholesterol particles, the white blood cells, stick to the arteries. If the lipoproteins get retained in the arteries, inflammation starts occurring in the walls of the arteries. The immune system gets activated, plaque starts to build up. The plaque will have cholesterol, white blood cells, smooth muscle, and calcium in it mainly. The soft plaque is more prone to rupturing. Think of like a red hot pimple. If it pops, then that cellular compounds float out into the bloodstream, the blood clots, and the person has a heart attack. The hard calcified plaques, they're more like a scar. If the artery becomes 70% occluded, the person will probably have symptoms when they're exercising. So they may have chest pain, shortness of breath, exercise intolerance that they have to stop, and then when they stop the exercise, the symptoms get better. So the hard plaques, you can treat with medications to get the arteries to vasodilate, and in refractory cases, then that's when stents may be useful to relieve the symptoms. But the stent does not reduce the risk of having a heart attack, and the stent does not reduce the risk of dying from vascular disease. It only relieves the fixed obstruction so the person's symptoms get better. The main thing you're concerned about are the soft plaques that aren't seen on calcium scores, and the soft plaques need to be treated. How to do that? Optimize nitric oxide, keep inflammation, oxidative stress low, and then use whatever tool you may need to keep your lipoproteins at the range appropriate for the vascular risk that you're at. But a good reference range is generally an ApoB less than 70. All right. This is a good question. Definitely not an expert in this one, but enough that I would probably be buyer beware in my mind. But any truth that EVs like the Teslas being bad for mitochondrial health because of the non-native EMF? The short answer is probably. It's enough of a concern that I won't have an electric vehicle myself. I have been in a Tesla before, and I brought my meters. And interestingly, the meter wasn't that high in the driver's seat. I wasn't driving; I was in the passenger seat. The RF fields were in the red zone on the passenger seat because, at least this model, the batteries must have been closer to the passenger. So buyer beware in these. High EMFs definitely have an effect on mitochondrial function. They open the voltage gated calcium channels, which then causes issues with nitric oxide, which then causes issues with inflammation. So I personally would steer clear from EVs if you have any type of issues with your mitochondria. All right. Then I think this is the last pre-submitted questions. I've seen a few popping up in the comments, so I'll jump into those in just a second. Are nitric oxide supplements beneficial? Short answer is generally yes, but test don't guess. The one the person's familiar with has vitamin C, L-arginine, citrulline. And then if you like it, when should it be taken? And only in conjunction with exercise. So short answer is that people are not generally low in arginine. The issue is that they have an issue with the endothelial nitric oxide synthase enzyme, or eNOS for short. As people age, this enzyme becomes less effective at converting arginine to citrulline. So in the presence of oxygen, arginine will be converted to citrulline and nitric oxide. So if you lack the eNOS enzyme, it's like putting fuel into a fire that there's no fire to burn the fuel source. So it won't work for everybody. In younger people, it may still continually work. So generally prefer products that actually release nitric oxide when they dissolve in the mouth, or things that have precursors that help the body improve endothelial nitric oxide synthase. So I wouldn't take a arginine alone supplement if you're really trying to support nitric oxide. Time of day, generally take it in the morning time for some of these that are capsule based. For lozenges, oftentimes it's one tab twice a day. So, question about beetroot pills, possible. Probably need at least 300 to 400 milligrams of nitrates in them before they would work. So you'd have to know what the manufacturer claims is the nitrate concentration. But again, it's one of those test don't guess type of things. If it's something you've already acquired, then potentially want to test salivary nitrite strips. You could check your blood pressure. You could check arterial elasticity. If you have a Oura ring, you can look at the cardio age. If your cardio age is aligned with your biological age, it may be working for you. So they might be useful, but best to test. Somebody's asking about, have I heard of, I think this says Ninja, or I can't really read the words too well tonight on Instagram, but have not heard of this particular brand. Most of the time, I usually recommend people consider something that Dr. Nathan Bryan would have formulated. He's one of the world's experts on nitric oxide or Calroy. And in full disclosure, I've spoken for Calroy before as a paid speaker, but it's products that I've tried myself or have many of my patients on and seem to work well for them when we're testing them with our more sensitive devices in our office. So that's what I would usually recommend. All right, great questions tonight. I know there's a lot of new faces, a lot of new followers, so welcome. This is what we do every Monday, 6 p.m., usually about half an hour. We answer the pre-submitted questions, and then if there's more time, answer anything that's coming through as the comments. So we'll hit some of these now. Still scrolling. All right. What is my view on the Clearly scan? Great question. I talked a little bit about it in the podcast I did with Dr. Lyon 3 years ago, but did have some comments about it yesterday's podcast. It's a AI overlay software platform that looks at CT coronary angiogram images and quantifies the plaque. It gives you total plaque volume and the percent atheromal volume, but it will also tell you what type of plaque you have. So the question earlier about hard versus soft plaque, it will give you the percentages of the plaques that you have. I personally had the test done twice. I have a strong family history of vascular disease on my mom's side. with my grandma, having her first cardiac events in her 40s. So I started screening myself. I'm not going to be cavalier about my own vascular health. This is what I do all day long, looking for vascular risk. So got myself screened, and maybe I didn't like exactly what I saw, so was aggressive with things. And when I repeated my scan, the total plaque volume shrank 6%, which, if you know essentially how did that happens, you will see it happen. I've seen many of my patients' plaques regress. I definitely talked about it relatively at length in the podcast I did yesterday, was that recent keto CTA trial. They definitely used the clearly scans in those individuals. The too long don't read take home is that those people's plaques increased in 1 year on their diets. So probably would be much more careful with saying that being a lean mass hyperresponder is necessarily neutral for vascular health. And do I have a favorite form of magnesium? Not particularly, but many people are deficient in magnesium. The body needs magnesium for well over 300 processes. Typically just don't recommend magnesium oxide. Magnesium oxide is not well absorbed through the GI tract. So really good if people have constipation, but you generally want to use something that's better absorbed. So citrate, malate, glycinate, tartrate, threonate, one of those. But some of them have a little bit better blood-brain barrier penetration, so it really depends on what you're using the magnesium for. And somebody put in, it wasn't Ninja, it was Vinia. No, I have not previously heard of that particular nitric oxide promoter. All right. So I think I got through the comment questions as well. So I'll wrap up here in just a minute. But for those that joined a little bit late, this happens every Monday, 6 p.m. Central Time. The archives will be in my feed right after we're done chatting tonight. And oftentimes I take these videos, put them on my YouTube channel, and it'll have like an AI kind of summary of what we discussed. So my YouTube channel is just my name, drtwyman.tv. It'll link over to my YouTube feed. There are some longer form videos there. So some of the more popular ones are the No Time to Die presentation, where I go through how to screen for vascular disease and some of the treatment options. And then also I've done a couple previous talks where like how to interpret your own lab reports, going over my own labs. So it's basically like how a cardiologist interprets his own labs, I think is what one of them was called. So the two housekeeping things I started with at the beginning was that, yes, I'm still open to new patients. After this podcast with Dr. Lyon drops, don't know how long that will be, that I can stay open, but my goal is at least for this year. If you're interested in potentially working with us, if you go to my website, drtwyman.com, there's an application, and one of my team members will reach out to you. In 2026, there will be an option to be a member of my practice, Apollo Cardiology. I don't have a total head count that I'll say we're going to limit to just at this time. I'm working through those numbers with my team, but stay tuned on this feed. And also, if you're on my newsletter, there's going to be a newsletter this week that explains a little bit more details with that. And also in the final discussions with the Canyon Ranch on having a kind of low-key type of retreat. So if you're interested in potentially hanging out with me in October, November, I can kind of give you the play-by-play of what I do for my own well-being, how I think about nutrition, exercise, stress management, and sleep. So I appreciate everybody's time and attention tonight. Appreciate all the new followers. When the podcast with Dr. Lyon drops, I'll let you guys know. So have a great week, and we'll see you next time.